Thank you, Sylvia. It's my pleasure to welcome you back here after a short summer break to our seminar and training series. And it's my great pleasure to welcome Olivier Michielin here as our speaker today. He will talk about the Swiss Personalized Oncology Project. It's actually the largest SPHN project when it comes to data providers, so covering not only the university hospitals, but also the periphery, so to speak. And it brings also another partner to SPHN, which is the SAKK, the Swiss Group of Clinical Cancer Research. Olivier is an MD PhD. He has also a master in physics, as I just learned right now. And he is head of the Personalized Analytical Oncology department, the head of the melanoma clinic, and the Department of Oncology at CHUV, also a member of the Swiss Institute of Bioinformatics. Olivier, thank you very much for making the way from Lausanne to Basel, and it's good to have you here. Thank you.
Thank you so much, Catherine. Well, it's a great pleasure for me to be here. I think you know, what has started with SPHN and DCC is really fantastic. I think we see great opportunities for the future, and we are extremely happy with the collaboration that we have with you guys. We'll be regularly knocking at your doors in the months and years to come. I think we have many questions to be solved. So I would like to start by just giving you a flavor of where we're going scientifically first, and then what type of data do we need to gather, and what are the hurdle, the pitfalls that we're facing. I think it's really a very interesting, fascinating time in oncology, because we are breaking a lot of boundaries. We start to have, for the first time, curves of survival that looks like this. That means we start to have a very flat curve that extends up to 10 years, probably now 20 years, where patients are basically disease-free or not, strangely enough. They don't have treatment anymore. They were treated maybe for 3 months in this region here in time, and they basically are doing perfectly fine. So we call that a functional cure, something that we didn't think was possible even a few years back. But the question is that the plateau for a given treatment option is not very high. You see here, I depicted something around 20%. It's the case for many disease types where immunotherapy can do that. The question is, if you have a treatment that does 20%, is that a good treatment, yes or no? Well, if you can actually paint those patients in the correct color and only give treatment to the orange one, it's the perfect treatment. The question is, what do you do with the rest? Well, you should have many pens in your toolbox, and you should be able to paint in blue and then paint in purple until you've covered a decent fraction of your population. So that's the goal of precision oncology. It's really to tailor the treatment to small subgroups where the benefit of your treatment is extremely high. And so the challenge is, of course, very, very big, because that's going to increase efficacy by a tremendous amount. It's going to also reduce cost, because you're only going to deliver the treatment to those 20% that will deliver the long-term benefit. And so the perspectives are very fascinating if we can achieve this together. I mean, of course, we're going to increase not only efficacy, but decrease the cost of our treatment. So clearly, very important matter here. Now, if you want to do this, you can use many different aspects to guide treatment decision. One of them is to use clinical trials, as we are all used to. So if you have a heterogeneous patient population, what you do usually when you run a trial is that you're going to restrict the viability of your sample by putting inclusion criteria, for example. That means here I'm selecting only the patient that satisfy the same inclusion criteria. Then you do a randomization. So you're going to compare, for example, your new treatment against the standard of care. And in that context, you usually come up with a very sound and clear answer with all the statistics that go with it. So you are really able to say, okay, in this case, the experimental treatment is better than the standard treatment, and you can move on. The problem that we have in oncology is that the number of cases where we're going to use the same inclusion criteria, the same population in our practice is very small. Actually, this has been quantified, and we know it's small. And what we usually do is we take the treatment that was validated in this population into the general population, and then what happens there is less clear than what we had in the clinical trial. And sometimes we might be applying some treatments that are not the perfect one for our patients. So can we use real-world data in complement to this? We believe yes. So the question is, can we capture what happens to all of these patients so that at the end of the day, we are able to generate complementary data that allow us to guide treatment decision in this more complex landscape, i.e. the real-life landscape. So to finish up with this introduction, I think what I also wanted to say, which is quite important, is the fact that we need to type the patient very accurately from a molecular point of view. So we need genomics, metabolomics, proteomics, whatever, to really know as much as we can from the tumor. We also need very precise clinical data to be able to categorize where the patient is in his history of treatment. But this per se is probably not enough to actually guide treatment decision. We really need to have also reference data so that we can see whether this particular event at the molecular level or this clinical data deviates from the norm, is associated with other things. And the only way to do that at the moment is to have a large reference onto which we can compare the data. If you have both an accurate description of your patient and this great reference data set, using machine learning, AI, whatever, you are able probably to guide a sound precision oncology program. So that's exactly what we want to do. And I'm sure when you see this, SPHN comes in mind very quickly. So we need to build together this reference so that we have something to compare to when we analyze the next patient, basically. So what can we do to actually bring this data together? Before going into the SPO, Swiss Precise Oncology program, I'd like to show you what we have done internally within our hospital, because that's probably where I know most of what we were able to collect in terms of data, but I hope we'll be able to do that at the scale of the country very soon. So that's an example of some data types that we're trying to gather at the moment. So clinical data, environmental data, genomics, digital pathology, blah, blah, blah. And we want to integrate all this into a clinical decision support to be able to say, Mr. X with that mutation, that exposition to drug, and that prior response to whatever treatment is a candidate for that next line that should derive the biggest benefit. Now, an example of what we have done at CHUV is to code and structure the electronic patient record from the beginning. So an example here with toxicities, sorry, it's in French, and that's actually a big hurdle that we have in SPHN, is that we have to do everything multilingual, which doesn't simplify our life, but that's the way it is. You see here that, for example, the toxicities are not a free text, a narrative from the doctor, but it's really codified. So the patient has grade 2 diarrhea, grade 1 nausea. And that's, of course, much easier to use in terms of data mining afterwards. Requires a little bit of input from the doctors, but I think once the doctors are used to work with this, by the way, international norm, they like it a lot. And it's also much easier when you go back to the history of your patient to know how these symptoms have evolved, rather than having to read each time a large narrative and try to guess what was the grade of toxicity. So we have to do the same for all the other metrics. So for example, the stage of disease is not fully categorized, what type of response to treatment we have had, what treatment lines, what is the survival. So all of these very important metrics for oncology are all hard-coded into the electronic patient record. And of course, we also have the additional data like the molecular profile and so on and so forth, so that we can match the data together. So that's what we are building at the moment. And the grand goal is, of course, that, I mean, the same process is happening in most hospitals across the country, university hospitals. So now we want to be able to actually use SPHN to render these data types interoperable and to be able to assemble them to get the critical size so that we can do statistical inference on these. What can we do with this type of data? So roughly speaking, we have three types of data. We have structured data that I've represented here, non-structured data, that's the free text from the doctors, and finally those shared data that we hope to exchange in the very near future. Now, what can you do with data mining? So there are several options. One that is quite interesting for our hospital is to build indicators. For example, if you have a toxicity from a treatment, that toxicity is expected, but only to a certain frequency. And so if you deviate from your normal distribution, you should be able to capture that. So that's a way, having these data sets being generated automatically, to spot this. And of course, the greatest interest is personalization of treatment. So that's the goal of the program I will show in a minute, SPO, to really build an engine that is able to predict what will be the best treatment option for a given patient. And so to do that, we need vast amount of data, and we believe really SPHN and DCC is the best way to aggregate this. And of course, additional research question, you can see that personalized treatment is not within research application, because there is a big debate. Is that clinical? Is that research? It's not so clear. If you're using all of this information to finally treat the next patient, it's sort of borderline between pure research and clinical care, so to speak. So just an example of the type of information that you can get out of a university hospital. That's what we get at CHUV. So now we have around 65,000 patients that are electronically tagged in our hospital as oncology patient. And for most of them, we have partial data set. For quite a few, we have actually full data set that comprises diagnoses, treatment, responses, and survival. So that's the essential data that we have for a lot of patients. But just to show you that to get the treatment is actually not a very simple thing. So for example, at CHUV, what we had to do was to get the treatment plan from the prescription system, but then as we do this query, we also need to do a parallel query to the billing system. And the billing system is the safest source of information to know whether the treatment was delivered, yes or no. So you have to basically know your landscape. You have to know how your hospital works to be able to extract the correct data. And that's, I think, one of the challenges that we have is that we have engaged in the program I will show in a minute with medical oncologists, with people on the ground, to be able to capture the correct information at the correct place. And the only person who can really do that are actually the doctors themselves, because they know, oh, but for these patient types, we have a molecular tumor board, or we have that tumor board that records this data systematically. And then that's your source of information. So I think it really requires to really infiltrate and embed into the clinical care if you want to be able to get the data in the most proper way. I think, of course, we do that iteratively. So we have treatment line, response, yes, no, next treatment, response, yes, no, and so on and so forth. Of course, all the data that I showed here is an attempt to get structured data to really categorize your patient. But of course, the richness of what we have in the electronic patient record is much higher. And we have those narratives from many doctor types. So for example, the pathologist will write a narrative about what he sees under the microscope. The radiologist will write a narrative about what he has into the CT scans that follows the patients on the lines of treatment. So we want to make use of that, and within our program we are trying to actually get for example an automatic reading of the pathology report, an automatic reading of the radiology report. So this is really at the infancy as we speak now, but we have started, for example, to use a very rudimentary NLPs to try to understand what is encoded into the narrative of the radiologist. And that's an example here. Just a very simple support vector machine here allows you to get a reasonable accuracy in trying to understand whether the patient is responding to treatment, yes or no. So that's very important, because although this was based on a very limited of maybe 120 radiology reports, now we're extending that to 100,000 radiology reports. And if we are successful and we can quote reasonable accuracy, of course, we'll run that to the 70K patients that all have this radiology evaluation in written form. And that's going to start to look like a very interesting data collection to have an algorithm that learns from these data sets. So there is a great challenge to be able to do that, because that could automatically build our retrospective cohort on which we could start training an AI system to be predictive. So that's why we're actually embarking into these considerations here. Now, what about genomics? Genomics is, of course, one of the most important data type that we are generating in oncology. We need to be able to characterize the tumor in great details at several time points. The first time point is, of course, the beginning here, when you are actually typing the patient for the first time and try to decide what is your best first-line treatment depending on the genomics of your tumor. But what happens usually is when you apply a treatment, you're going to put a selective pressure on your tumor cell, and that's going to reshape the genomics landscape of your disease. So usually what we try to do is to rebiopsy the patient on treatment or at escape, so that we can compare what's happening now in this resistant tumor compared to the original tumor. And that's highly informative, and that's also something that can help guide a precision oncology program. So that's basically, very difficult to organize on the floor, because you need a great timing. You need time to biopsy the patient before you jump on the second line, even if there is a pressure to do so. I mean, so you have to basically be able to do the biopsy on spot when you see the patient and when you realize he's progressing. So there is a lot of logistics around that, but we're trying our best to actually move towards that direction. Just an example of the infrastructure that we put in place at CHUV to handle this genomics data. So we start from the raw data. We have an I2B2 integration, and then we have some clients on top of that, CBioportal being the most frequently used tool that we use to visualize the data. And then finally, we have, of course, the additional layer of algorithmics to learn from the data, which I've just put at the lower part here. Just to show you that, in case you were scared that this was not going to be complex enough, it will get much more complex very quickly. That's an example of what we do currently, and this is single-cell RNA-seq. So when we do biopsy to the patient, we split the sample into single cell, and then we do full RNA of each single cell. And then what you see here is basically a clustering of each point here is a cell, and we cluster the cells according to their transcriptomic profile. And doing so, we can assign the cell type. So for example, in these melanoma samples, we see T cells, we see tumor cells, we see fibroblasts, we see endothelial cell. Basically, we see the whole composition of the tumor at the transcriptomic level. And this is very important because it allows us to understand how cells are talking to each other by looking at the RNA expression. Just to show this, because for one biopsy now we get around 5,000 single-cell RNA profiles being computed. So that's huge data set for every single patient. So just, I think it's important to know that from the DCC point of view, we're moving towards big data at a very fast pace. And I think, if you factor this, then maybe the radiology data plus a few additional, I mean, we're going to get into massive data sets very, very, very quickly. So how did we try to tackle this question at the level of the whole SPHN consortium? So we submitted a proposal called the Swiss Personalized Oncology. This was a driver project. And the aim of the project was really to try and federate as much as we can from Switzerland. And we were actually very pleased when we read the description of the SPHN initiative. For us, what was really striking was the idea of talking the same language at the different places in Switzerland. And this in oncology was a challenge. We believe we are moving the right direction very fast. But just to give you an example, how you call the treatment in Basel and how you call it in Geneva is a big challenge, because some of those treatments are just not one drug, but it's maybe 5 different drugs. And so how do you make a systematic on calling this? So we came up with a naming convention and some rules so that we can call the same treatment the same way, and of course match back the patient to the same cluster at the end of the day. So that was an example of one of the difficulties that we have had at the beginning. So what we have done was to merge two driver projects, one from Basel Zurich and one from Bern, Geneva, Lausanne, and SAKK. And we joined forces. So this was actually led by Momo Bentires, and this one by us. And we actually had by design already SAKK. So not only do we regroup all the university hospitals, but we also group the non-university hospitals. Like, you know, I've listed a few here, but basically that's everything else in Switzerland. So, you know, most of the centers are actually listed in there. The advantage of that is that in terms of pure volume, I think we're going to get much more mileage. Clearly, I think 70% of the patients are actually treated outside of university hospitals. So it really shows that this is an important aspect for oncology. But also, I think we don't want to create, you know, a two-speed system where, you know, the oncology university hospital have very nice way to generate this data, and then it's different for the non-university. So we want to be able to really make this effort global in Switzerland, and I think that's probably something that can be achieved. And so we have very good collaboration with all these non-university hospitals, and I'll show you how we want to engage them into the process. So I mentioned that we were actually two drivers, one from Momo Bentires for the Basel Zurich cluster, and then another one from our side. And then we were actually very lucky to have also Mark Rubin with a very similar spirited project, but based more on pathology, that was able to you know, synergize with us. So basically, we had one of our work package that was the genomics data acquisition that, you know, was completely transferred to Mark, because this was really one of the key goals of his project. So now we have basically two driver project that's run in parallel, but we have all our meetings together. It's basically almost as they were fused. I mean, they're not technically speaking, but I think in terms of the capacity to exchange information and to co-lead this, I think it's absolutely ideal. We have great collaboration with Momo and with Mark, and I think it's really something that has changed the landscape quite significantly in Switzerland, and we are very fortunate for this trio that you know, SPHN was able to create for us. So what do we want to do? So we want to be able to capture clinical data. You see here structured diagnosis, structured stage of the disease, structured treatment line, structured evaluation from the radiology. So that's the raw material that we want to get from every single patient. Molecular data, usually panels of genes. Those are somatic alteration that we want to record. And then finally, you know, enhanced data types for molecular and cellular data. I showed you, for example, this single cell RNA-seq. It's just, you know, few examples. I mean, we don't want basically to leave any data type outside of the equation. And of course, how can we go further into the deep phenotyping of our patient? Can we read the radiology report and deduce whether the patient has brain metastasis, yes or no? That's a very important discriminant in the history and the treatment of the patient. So clearly something that we want to capture as well. Based on all of that, we want to be able to basically pinpoint the patient to the different treatment lines. What we are trying very actively to do is to do this automatically. So rather than having a system where the data is post-processed by data managers and then feeding a data warehouse, we want to change the input from the doctor. So we want to be able to change the electronic patient record so that the correct items are captured by the doctors themselves and then fall back into the data warehouse. So that's why in our project, the representative from each university hospitals are at least contain some medical oncologists, because these might be able to change the electronic patient record locally so that, for example, you know, you have the correct structured field so that we can actually spot the information and be able to move forward in the data warehouse system. An example of the work packages that we are working on at the moment. So WP1 would be the data acquisition in the university hospital. WP2 would be the molecular acquisition. So that's the one that is now being actually led by Sosib and Mark Rubin. WP3 is a way to engage the periphery, not only the university hospital. And then WP4 is the establishment of a Swiss-wide molecular tumor board. This has started since almost a year now. It's quite interesting. And finally, how can we link this database that we're creating to samples, live samples, large data sets? And that's work done by Zurich and Michielin quite successfully, and hopefully at some point we'll be able to assemble the two. So that's still, you know, a big challenge. How do we, you know, generate codes so that we can identify the patient throughout the whole country? So these are some of the hurdles that we still have to face. So just an example of the clinical data. So that's actually not the real list. It's, you know, something that you know, summarizes the type of data that we are capturing. And at the moment, our minimal data set is no longer minimal as we expected. So everyone came up with its, you know, favorite data type to gather. And finally, we decided to have sort of a complete data set. So now we have 117 items that are being collected, and some of them are of course repetitive. So for example, treatment, response, and so on and so forth. So it's a big effort, but what we have done is we have prioritized the treatment or the response or the different items so that we basically have optional fields and fields that are completely mandatory. So with this, we believe we can still reconstitute the important aspect of the oncology history of the patient, yet some of the fields that are missing are not blocking for most of the centers. So that's an example of where we are now. And then for the work package of Mark, the idea basically is that they want to put a standardized way to call alteration, mutation when you use next generation sequencing. And one of the goal is to have a common database for Switzerland for all the mutation. And that's, for example, a cohort that we have in CBio portal that can be used by different hospitals. And that's basically where we're moving. So that's a cohort of our molecular tumor board where we can actually see that our patients usually have an exclusion between NRAS or KRAS, I mean, things you would expect. But that just shows that we're hopefully also going towards homogenization and uniformization from the molecular point of view. So I've said that basically the university hospital all work with a data warehouse system, whereas the peripheral hospital, some of them start to have a data warehouse, but most of them don't yet. And so we need an easier way to access information and to engage them. And so we are in the process of developing web-based solution. And the idea here is that the web-based solution will allow them to upload data to the network, but of course also to get a benefit from that and to be able to look at, for example, what happened to patients with similar properties in the network, how were they treated, and what was the outcome. So that's the sort of return that we want to be able to provide to the non-university hospitals. And that's an example of, you know, a web-based solution. So we are working on two different types of solution, one based on RedCap and another one on SecuTrial. SAKK has a great expertise in SecuTrial, so that might be the preferred solution. We are more on the RedCap camp, so we'll try to have a mirroring versions for the centers that are not used to SecuTrial, for example. So that's a little bit where we stand at the moment. So these eCRFs are almost ready to fly based on the latest version of the minimal data set of 117 items. So hopefully we should be able to deploy that, let's say by the end of the year, beginning of next year, or something like that. A word on the molecular tumor board. So we developed a Swiss-wide molecular tumor board with the idea to be able to extend what regional tumor boards are doing. And I would like just to show you the example that we have in Geneva, Lausanne, where we have created a molecular tumor board for the periphery. And I think it's an interesting example where we can really engage with the periphery. It follows a little bit this discussion with the non-university hospital. And that works actually quite smoothly. So basically, a regional hospitals that wants to use a precision oncology program for a patient will send us a request. Then we get the material, we perform the omics, we get the electronic patient record data, and then based on that, we can propose an off-label treatment. So for example, a drug that can be used out of the label because we have a molecular alteration that tell us these patients should be sensitive for this, that, or the other drug. Now, we can also pinpoint the patient to a clinical trial, and then we transfer the patient to do the trial, and then the patient goes back to the center once this phase 1, phase 2 trial has been done. So this has been implemented in our region. We then talk to the medical oncologist through a video system, so they can basically attend the tumor board with their iPhone. It's actually very convenient for them. They can just go out of the room where they see patient and just in 5 minutes connect at the right time and discuss what to propose to the patient with us. It's quite nice. You can see that we have now quite a momentum. We are getting around 350 patients per year, so quite a volume. We could have more, but we're trying to basically limit this because we don't have yet the resources to crank up. But it shows that I think there is a need for this type of proposition. An example of a pancreatic cancer that responded to a cocktail of 2 targeted therapies, something that is quite rare. Those cancers are very difficult to treat. It shows that, knowing some of the alteration that the patient had, we were able to propose an innovative combination that worked quite well. We have a few other cases of pancreatic cancer that have responded the same way. And here, another example, a young patient with a sarcoma that was escaping chemotherapy. When we did the analysis with NGS, we realized that he had an amplification of PD-L1, which is an escape mechanism to the immune system. And this prompted us to treat the patient with a PD-1 inhibitor, and he went into a near complete response very rapidly. And now the patient is still doing fine when he was completely progressing on chemotherapy. So it really shows that precision immuno-oncology is also something that can be targeted with this program. And so that's something that we're going to push a lot in the years to come. And so to conclude, I think we really believe that if we are able to assemble all these humongous data set and heterogeneous data set among not only the university hospitals, but very importantly, all our colleagues and friends from the non-university hospital, I think we'll be in a very unique position where Switzerland, having a very stable basin of population, will be able to track the evolution of the patient throughout several lines of treatment, even if the patient is changing hospital, because we'll have hopefully everyone on board. Something that is probably a bit more difficult to do if you're at MD Anderson, because at MD Anderson you will have a lot of patients that are referred for a clinical trial, but then they leave, and they might not be in the same system afterwards, which means that Switzerland could create one of the very high quality data set using this strategy, and that's exactly what we want to do. In order to do that, we need to be all on board, and I think we are extremely fortunate and happy to see that our colleagues from the university and the non-university hospital are really joining forces in this program. What we hope is that by just better selecting the patient for a given therapeutic intervention, we are able to raise the bar and to really bring the long-term benefit to a larger number of patients in the very near future. I think I'd like to really thank everyone who has contributed to this. I mean, it's a huge project. I think you have the list of the stakeholders on the website. I think this just shows the different institutes that are involved. So I think we are extremely happy to have all the university hospital, all the universities, the ETH, the EPFL, and also the non-university hospitals and the SAKK. So I think with this huge strength, I think we are to deliver in the years to come, and hopefully I think we're in a good shape to do so. And I thank you for your attention.